Hey, do you know your doctor's style of treatment? I don't mean if he's a snappy dresser. I mean the order in which they use medicines to control your MS. That's called a style of treatment, and it's a really important concept that's not talked about very much at all. I'm going to discuss it in this video, so don't turn away. That starts right now. Howdy! Thanks for learning about MS with me, Boster. This video is the finale in a series that I've been doing on disease-modifying therapies for multiple sclerosis. Leading up to this video, we've had discussions about the route of administration, frequency of administration, the various mechanisms of action of how these drugs work, their rank order efficacy based on my opinion, and the last video I did was on safety and tolerability. All of those points add up to allow us to now have this very important conversation about the style of treatment. Now, when I say style of treatment, I don't mean how sharp of a dresser is your neurologist, probably not very. What I'm talking about is the style they use when they apply the MS medicines in sequential order. As it turns out, there's a handful of styles that are used throughout the world by MS neurologists, and in this video, I want to share them with you. Why? Primarily because I want to make sure that you're familiar with your doctor's style of treatment, and I want to make sure that you and your doctor are aligned, making sure that style is right for you. So, with that preamble, let's jump in. The first style of treatment that we'll be discussing is escalation. So, the concept of escalation is as follows. I will start you off on a medicine which has a low efficacy, but a really lovely safety profile, and then we'll see how things go. And if you do well, then that's a great MS drug. I'm a great doctor, you're a great patient, hoorah! If, however, something doesn't work out, well, that's okay. We will upgrade your therapy to something that works better. Then if that second drug works out, awesome! Again, that's a great drug, I'm a great doc, you're a great patient, woohoo! And if that doesn't work out, well, that's okay, we'll escalate again. The thought process is that it's the perfect balance between the risk and safety of a medicine and the efficacy. And I think it's absolute bunk. Now, before I share why I dislike it so vehemently, I do want to share that it is the most common style used by MS neurologists globally. It's unfortunately not uncommon that a patient newly diagnosed with MS would be started out on a low efficacy self-injection shot or a low efficacy pill to see what happens. And then if that doesn't work out, they may upgrade to a more efficacious pill or maybe one of the monoclonals. This is the escalation model. Now, to take it a step further, there's slow escalation and fast escalation. Slow escalation is increasingly being looked down upon by MS neurologists, and it's falling out of favor, thank goodness. Slow escalation is where I put you on a low efficacy medicine, and boy, you have to have a tremendous amount of disease activity before I'll consider upgrading you. So we're talking multiple attacks, multiple new spots on several MRIs before I'll finally say, fine, we'll upgrade. Fast escalation, which if you're going to escalate is the right way to do it in my opinion, so where you put someone on a low efficacy medicine, admitting that it is in fact low efficacy, and then you essentially have a zero tolerance policy to quickly escalate if necessary. An example here would be I put you on a low efficacy shot and I check an MRI at 6 months, and if there's one new spot, we're done with the medicine and we immediately upgrade. Now the reason I don't like the escalation model is it's flawed in multiple places. First of all, the concept of making someone fail a medicine before they're allowed to have access to a better medicine is insane. Essentially, what we're saying is we allow the human being to accrue permanent brain and spinal cord damage because they've had neurological damage, they've manifested an attack, they have new brain damage on their MRI, and only then will we give them access to something which works better to control that. It doesn't make any sense. Also, the idea of if everything's going okay, then we're doing fine, assumes that the patient is completely forthcoming with everything that's going on, and the doctor is all-knowing and is not going to miss anything. And I think both those things are not oftentimes the case. I think the escalation model is a terrible way of treating MS. And I'm very biased, but I'm allowed to be. I mean, you're listening to me on my YouTube channel, and I just don't think that it's the best of ideas. Nonetheless, it's the most common style used throughout the world, and I want you to be aware of it. Hey, real quick before we go on, if you like this video, would you please give it a thumbs up? Also, if you haven't yet subscribed to the channel, please consider doing so. Those two actions are totally free, and they teach the YouTube algorithm that you really like this content and push it out so more people can benefit. Thank you. The second style that I would like to discuss is much more appropriate in my opinion, and that's the earliest application of high-efficacy medicines. So you meet a human being with MS and you don't waste time with low-efficacy self-injections or medium-range pills. You go straight for the big guns and place them on, for example, a monoclonal antibody. This approach has been studied, and it's been shown to have way better outcomes than the escalation model. I've done a couple live streams on this topic, and there are other videos on this channel where I've gone over that. Suffice to say, I think it makes a lot more sense helping the person long-term to try to control the disease up front. This is done routinely in other fields that are smarter than mine. So when you look at rheumatologists, when you look at HIV, ID doctors, and when you look at oncologists, they all figured out 15 years ago that they can control the disease better if they hit it hard up front. And that can be done in MS by the earliest application of high-efficacy medicines. An example here would be starting someone out on, say, Tysabri, or starting someone out, say, on Ocrevus. Now, one of the common critiques that I hear when thinking about the early application of highly effective therapy is, well, wait a second, what happens if they break through? We have nothing else to offer them, which is silly. Because now, I make this video at the tail end of 2022, there are multiple high-efficacy drugs. And so if you were placed on one and didn't do well, we can make a lateral move to another high-efficacy drug. And we don't have to go backwards to things that are less likely to work. The third style that I would like to discuss is one of my favorites, and that's induction therapy. Multiple sclerosis is a problem with the immune system, and you can induce the immune system to change. This is a really interesting way of treating MS, one of my favorites, and it can be done with medicines like alemtuzumab, Limtrada, or with Mavenclad, cladribine, where we reboot the immune response. As I've shared in other videos, you take upfront risk and complexity. You reboot the immune response so that you can see a durable effect in the absence of retreatment. With these unique drugs, you can sometimes have situations where someone takes a therapy for 2 years, and now they haven't been on anything for literally years, and their disease is under good control. This is the induction model, used very frequently, again, in oncology and rheumatology, and I think it works really well. If I take it a step further, there are some patients where I do an induction, and then later I'll do a maintenance. So this might look like giving someone, say, Limtrada, and then a couple years into their disease, putting them on a maintenance pill to keep things at bay. So the induction model is one of my faves. It's also one that is really challenging for people to understand because most humans are used to taking medicine on a regular basis. So I use the example that I have high cholesterol, thanks mom and dad, and I take a cholesterol pill once every day. It's a continuous medicine. These induction therapies are discontinuous, and so there are some emotional hurdles to jump through to feel comfortable with doing that kind of therapy. There's one more style that I want to talk about because it's kind of important and contentious, and that has to deal not with starting a medicine, but with downgrading or stopping a medicine. There are some of my colleagues around the country that for some reason, which is beyond my understanding, are acting rather ageist. They have decided that if you reach a certain chronologic age, well, you don't need to take MS therapies any longer. And I think that's complete and utter bullcrap. I vehemently disagree with that. Now, their rationale is, as a human ages, their immune system can quiet down, and the medicines haven't been thoroughly studied in older patients, and so maybe we shouldn't do that, which is stupid. Because when we study this, and you take someone who is under good control on an MS medicine with no disease activity for years, and you stop the medicine, a third of those people will go on to progress in neurological disability. And if that third includes my mother, I am not okay with that. What I do think makes more sense, not to stop the medicine, but to de-escalate the medicine. And so you can imagine someone being on a high efficacy therapy, which might have some associated risk. And as they age and as their disease is under good control, you may de-escalate, put them on something which is less efficacious but has a more attractive side effect profile. To me, this is a much better balance than stopping because someone's 55 or 60. Have you thought about your doctor's style of treatment? See if you can kind of figure out how your doctor treats. And when you talk to them next, bring it up and say, hey, do you like escalation? Do you like fast escalation? Do you like slow escalation? I think it's a worthwhile conversation because they are using that style to treat you. And I think it's important that you know the style they're using. My name's Aaron Boster, and as always, thank you for learning about MS with me. The most powerful thing you could do to help this channel is to watch another video. So if you want to up your game, click the video that's on your screen right now. And until my next Monday morning video or monthly live stream, or even better yet, the next time I see you at the Boster Center for MS, this is Aaron Boster saying be safe and take care.